Good morning and welcome to the April 17th meeting of the Patient Protection Commission. We're going to go ahead and get started. Chair Sexton, I'll hand it over to you.
Thanks, Dylan. Good morning, everybody, and welcome. My name is Bethany Sexton. I'm the chair of the Patient Protection Commission, and I'm now going to call the meeting to order. Dylan, if you'd like to do roll call for us, that would be great.
Definitely. Commissioners, please identify if you are present when you hear your name called. I'll start with the voting commissioners. Dr. Jonathan Chastain.
Present.
Dr. Mark Glyman.
Here.
Dr. Ikram Khan.
Present.
Ms. Marilyn Kirkpatrick. We'll mark her absent when she arrives, or here when she arrives. Dr. Andrea Peterson.
Present.
Dr. Adam Porth.
Here.
Dr. Travis Walker.
Present.
And Miss Bethany Sexton.
Present.
Moving on to our non-voting ex officio members, Insurance Commissioner Ned Gaines.
Present.
Director Stacy Weeks.
Present.
Executive Director Janelle Davis, but I believe Joseph Filippi is her designee.
Yes, I'm present. Thank you, Dylan.
Executive Officer Teresa Karsten. We'll mark her absent and present when she arrives. Chair, that concludes roll call and we have a quorum.
Great. Thank you. We will move on to item number 4 for possible action.
Sorry. Agenda item 2.
Oh, I'm sorry.
Public comment.
Thank you. Yep. No, let's not skip that.
This item on the agenda offers an opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment telephonically, you may join the meeting by dialing 775-321-6111, and when prompted to provide the meeting ID, enter 981-401-478#. Please press *5 to raise your hand during the public comment period to provide your comments. Comments will be limited to 3 minutes per person. Persons making comments will be asked to begin by stating their name for the record and spelling their last name. If you wish to provide public comment, please raise your hand or press *5. Thank you. Yes, somebody has their hand raised.
I don't see hand raised.
Please begin whenever you're ready.
Hi, Executive Director and PPC Commissioners. This is Shelley Capurro on behalf of the Nevada Association of Health Plans, and my last name is Capurro, which is a statewide trade representing 12 member companies that provide commercial health insurance and government program services to Nevadans. Thank you for the opportunity to provide comments on how to address issues affecting moms and babies in Nevada. We did provide detailed written comments on March 31st. I'm just going to summarize those here. With approximately half of births in the United States covered by Medicaid, state Medicaid programs are acutely impacted by the financial implications of these growing trends. There are opportunities for Medicaid managed care programs to develop strategies to address prenatal care management and postpartum coverage strategies to improve health outcomes among pregnant individuals on Medicaid. Core to achieving these outcomes are policies and program design features that center on the following 4 key areas. Number 1, prioritize actions that address the disparities driving inequities in maternal health outcomes. Number 2, ensure access to a comprehensive range of clinical and non-clinical services and supports. Number 3, continue advancing the care model through enhanced digital modalities. And number 4, strengthening data sharing and incentivize plans and providers to improve management of chronic and complex conditions, including substance use disorders. Finally, NVAHP would like to emphasize that while these strategies provide a strong foundation for providing maternal health outcomes, their effectiveness and success depends on sustained, adequate, and long-term funding. to achieve meaningful, equitable impact, reliable investment to support implementation, to maintain provider capacity, advance digital tools, and ensure access to both clinical and non-clinical services is necessary. Without stable, ongoing financial support, even the most thoughtfully designed policies and programs cannot achieve meaningful or equitable impact for pregnant individuals and families. Lasting improvement in maternal health requires not only thoughtful policy design, but also coordinated, ongoing financial commitment from the state and its partners. We look forward to collaborating with the PPC on these policies and remain ready to partner on important policy initiatives as they arise. Thank you.
Thank you. Is there anyone else wishing to make public comment at this time? Chair, I see no one else wishing to make public comment.
Thank you. Now we'll move on for possible action on the review of the meeting minutes. These minutes were distributed to commissioners prior to today's meeting for review. Do any commissioners have any questions or edits or anything about the minutes? Otherwise, I'll open for a motion to approve the minutes as written.
Motion.
Is there a second?
Second.
Second.
All in favor, please say aye.
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 Anyone opposed? All right, the minutes have been approved. We'll continue moving forward on to a presentation on perinatal health policy and considerations from a hospital perspective. And we have Pat Kelly, I believe, from the Nevada Hospital Association, and Blaine Osborne from the Nevada Rural Hospital Partners here to present today. We can see your screen. Thank you for being here today.
Thank you very much for the opportunity to present this morning. My name is Patrick Kelly. I'm the president and CEO of the Nevada Hospital Association, and I have a co-presenter today who I'll let him introduce himself.
Hi, good morning all. I'm Blaine Osborne. I am the president of Nevada Rural Hospital Partners. I also have the honor of serving in the state assembly, and I am Pat's sidekick.
So the way we work this out when we arrange it, and I don't tell this to Blaine until now, that we'll be doing a presentation, and when you have questions, he'll take all the difficult questions and I'll take all the other questions. So getting prepared for that. But what we wanted to do was share with you a few things, statistics, information related to perinatal care from a hospital standpoint. And I wanted to start off with hospital capacity. You know, if you walk down the street and you talk to people and you ask them, does every hospital provide labor and delivery services? They would probably say yes, because that is kind of the general thought, but that isn't the case. So if you look at the state, we have 16 hospitals that provide labor and delivery services, 11 acute care hospitals and 3 critical access hospitals. Those are Humboldt General Hospital in Winnemucca, Banner Churchill and Fallon, and William B. Ryrie in Ely. And then we have 2 sole community hospitals that provide these services, and they are Carson Tahoe down in Carson City and Northeastern Nevada, which is up in Elko. So those are the hospitals in the state that provide labor and delivery services. We have 23 hospitals that do not provide these services. So there are 8 acute care hospitals, 10 critical access hospitals, and 5 neighborhood hospitals. And those neighborhood hospitals are in Clark County. That is where Dignity Health Common Spirit operates those 5 hospitals. With respect to NICUs, I know that there's been a lot of discussion about that. I just wanted to share that we have 10 NICUs in the state. There are 8 in Clark County and 2 in Washoe County. And I also think it's important just to kind of look at how healthy or unhealthy our babies are when they arrive in the state. So we have a higher low birth weight rate than the rest of the country. We have higher preterm births. And unfortunately, we have more women who do not receive adequate prenatal care compared to the rest of the nation. So I'm going to let Blaine talk to you a little bit about the workforce challenges that we see.
Thanks, Pat. Unfortunately, none of these workforce challenges that you're going to see are probably news to you all, because this has been a struggle for the hospitals in the state for many years now, and is continuing to be such. So you can see in OBGYNs per capita, this is another area where Nevada ranks very end of the bottom of the list of states. Currently only 367 OBGYNs statewide. That is that equates to 54 per 100,000, which is much lower than the national average of 80 per 100,000. One of the things we wanted to highlight for you all, though, is those average ages. And so the average age of OBGYNs in Nevada is 56. And almost half of OBGYNs in the state are over the age of 55 in Nevada. And so the question there is obviously, as those folks get closer to retirement, where are the replacements coming from? And so big concern there. I will say there is some good news coming. Just in February of this year, the University of Nevada, Reno School of Medicine, in conjunction with Renown Health, received their accreditation for their OBGYN residency. And that is expected to begin, I believe, in July of 27 with 3 OBGYN residents. Next slide, Pat. And then nurse workforce, of course, this is another one that we have spent a lot of time. We've spoken to this commission about the challenges there with our nurse workforce shortage. You probably are very familiar with a lot of these statistics as well. The one we really wanted to point out on this slide was that, as you can see there, the third bullet point, 40% of our Nevada nurse licenses are held by nurses with out-of-state addresses. A lot of this probably comes still out of the COVID pandemic, where we had so many travelers and out-of-state nurses coming in to work for short periods of time. We believe this is probably reflective of nurses across the country still maintaining a license in the state of Nevada, but we don't believe that all of those nurses are actually practicing in the state. This is one we've talked a lot about, the nurse workforce licensure compact, and there's other challenges and solutions that the commission knows very well. Some of the reasons that staffing is difficult in obstetric units, obviously births can happen anytime. Patient volumes can spike suddenly with little to no warning. Lengths of labor vary greatly, and that can be a big challenge. Obviously, emergencies pop up at any time, and then it's an all hands on deck kind of situation. And the specialized labor and delivery staff are very limited and very difficult to replace. I will say it's a concern we've seen in our rural critical access hospitals is that in the last few months, and I hesitate to call it a trend, but it is concerning, we've seen a spike in patient births in emergency rooms, which is something that I think typically most of our critical access hospitals will maybe see 1 a year. It's not something any hospital wants to have to do, but is always available to do. And unfortunately, we've seen quite a few in emergency rooms the last several months in our critical access hospitals. Next slide. I'll turn it back to Pat.
Thank you, Blaine. I wanted to talk about the financial pressures that are on hospitals, and there's some big headwinds ahead towards us. So to give you an idea, in our state, we have about 42% of our births are Medicaid babies, 51% commercial, other government is 4%, and self-pay, private pay, and charity care are 3%. Now, actually, just a year or so ago, Medicaid was over 50%. So that number has dropped. The commercial has gone up a little bit. So hopefully people after the pandemic were able to find jobs and get on commercial insurance. But also we saw an increase in other government payers and in self-pay, private pay, and charity care. Now, in that last category, a lot of those people really don't pay very much towards the cost of care. And in almost all those categories except commercial, the people receiving services don't even pay enough to cover the actual cost of the care we're providing. So that puts a real strain on hospitals. To give you an idea, the base Medicaid rate per diem for a newborn is $327, and that covers room and board, nursing care, supplies, medication, newborn screening, operating rooms, and all the equipment associated with that. And that's really not a very big amount of money. You can see NICU's higher, and so is the level for the mother to whom we're providing care, but it's still not very high overall. So we just thought we'd have a little bit of fun to show you what you can get in the Las Vegas area for $327. You can almost get a Golden Knights ticket. You can get a Raiders ticket, but I'm told that those are really bad seats, and it's much more expensive than that. The Wizard of Oz is $349, and one dinner at the MGM Grand can be up to $525 a person. So that's just to put a little bit in perspective that $327 is not a lot.
I'll just interject and say that the draft is next week and the Raiders are about to be much better. And so those tickets will be going up as well.
Okay. So in 2008, Medicaid developed a methodology that they used to establish per diem rates for babies and mothers. And basically what they put was 34% of the prior year's hospital billed claims data. So we just thought, well, what would that come out to be if we applied that to today? So instead of 327, we would be more around $1,731, which is about 5 times more than what the current rate is. And then you can look at the others as well. They're significantly higher. Now that's just an estimation. But here's the thing that happened, and I give a lot of credit to Medicaid and Stacy Weeks and her fantastic team at Medicaid. They realized that these rates were low, so they really worked incredibly hard to help us develop supplemental payment programs. So one of the big programs that we developed was the Private Hospital Medicaid Provider Tax Program. And this benefits 43 hospitals in the state. And what it basically does is the hospitals tax themselves. That money is sent to the state, and they send it to the federal government where it gets an enhanced match and then comes back to us in higher payments. And it has been a fantastic program in shoring up the hospitals. And one of the things I really want to emphasize is that only hospitals that are providing care to Medicaid patients get this benefit. So, the more Medicaid patients you take care of, the bigger payment that you receive from this program. And it has really been a game changer, and I give them a lot of credit for coming up with this program. And you'll see private hospitals. I just want to distinguish that private hospital doesn't mean for profit. What it means is it's a non-governmental hospital. So like Renown is part of this private hospital. Carson Tahoe is part of this program. But UMC and some of the critical access hospitals that are public district hospitals are not, because they're government hospitals. So that's the difference. They do have their own supplemental payment programs, and those programs also are going to have some headwinds headed towards them. So everything was going great. We got the program up just for a year and a half, and then all of a sudden HR 1 came along, and this is often referred to as the One Big Beautiful Bill. And it really gutted supplemental payment programs for hospitals, in addition to a bunch of other things. But this is one of the really big things that's impacting us. So starting in state fiscal year 27, we're probably going to see a $15 million reduction. And you say, well, that's not a whole lot. And it's not. But keep in mind that the state fiscal year and the federal fiscal year are different. So this isn't a full year. So by state fiscal year 29, we're looking at a $507 million reduction. And that is really significant. And when you go back to the slide where you see that, we've got almost 49% of people who are not paying the actual cost of care. And, we're in the 40s in terms of 40% and more for newborns who are Medicaid. This number is going to have a huge impact on our ability to provide services. So the RAND study came out just a couple months ago, and I thought it was interesting, some of the facts that they shared. And that is that Nevada is going to be one of 3 states expected to see the largest Medicaid budget reduction in the country. And Nevada can expect to see reductions of more than 15% of their Medicaid budgets. And over by 2034, we're probably looking at a $10 billion reduction. And this is just really significant, and it's going to be a challenge going forward. I've listened to a few of your meetings, and the one thing I haven't heard that has come up deals with medical malpractice pressures. And, you know, the medical malpractice premiums across the country have tripled since 2015. And we're seeing a lot of rate increases in 2024. But OBGYNs are among the top 3 specialties with the highest medical malpractice premiums. Now, you heard Blaine a few minutes ago talk about how many OBGYNs we have 55 and older. We know a lot of doctors at some point decide whether they're going to continue to practice or whether they're going to scale back their practices. Well, when medical malpractice premiums increase, it's not easy to scale back your practice because you still have to buy the policy and you don't have as much revenue to spread it over. So this is a really concerning trend, especially given how many older OBGYNs we have in the state. And I wanted to share with you just kind of an idea of, well, when these cases come up, what do they typically pay out? And basically the range goes from, for just a moderate injuries, $400,000 to $1 million. Now you think at $327 a day, how many days of care you have to provide to cover these things. And you look at the next level for a serious injury, like cerebral palsy, you can be up to 10 million. And for catastrophic injuries, it's even more. So this is really big. And of course, as these continue to hit, insurance companies are going to raise premiums, and they're also going to decide who they're going to write coverage for and who they're not. And that's very concerning, especially for the few rural hospitals that we have left. That's a lot of pressure on them. And then just a couple years ago, the Nevada legislature increased the limit on non-economic damages for medical malpractice cases. So we're going to go from $350,000 cap to $750,000 per cap. So, I mean, we're looking at $400,000 potentially more for each claim. And that will definitely have an impact, not only on the practitioners, but also on hospitals. So that's a big headwind headed our way. And so we are seeing a lot of financial pressure. We know we're going to receive less reimbursement for care that we're providing to mothers and babies, and that's going to put the perinatal care programs in jeopardy in the state. If the trend continues, we're going to see fewer hospitals offering OB and NICU services. Patients will need to travel further for care, and that will worsen maternal and infant outcomes and have higher long-term healthcare costs taking care of those babies for the rest of their lives.
Hey, Pat, I also want to add to this slide just on those financial pressures. They can kind of come from anywhere as well for some of our hospitals in the state. For example, we've recently seen some financial instability in White Pine County, and William B. Ryrie Hospital in Ely is supported, they're a county hospital district, supported by ad valorem property taxes. There was recently a threat from the county that the hospital might lose that source of revenue. And if that were to take place, then that would certainly mean that they would have to close their obstetrics and delivery unit and end those services in that part of the state. Now, luckily, I think we've been able to kind of put a stop to that, and the county and the hospital are working together for solutions. But those kinds of things can happen nearly at any time and threaten these services as well.
Thank you, Blaine. Yeah, it seems like there's always something just around the corner that we have to worry about. So I just want to go to the last slide, and that is you asked for potential solutions or policy ideas to consider. And so we just wanted to share a couple ideas. And the first is I've asked people if, if I were a pregnant woman or a member of my family was pregnant, where could I go to find all the information I would need about taking care of a baby and getting prenatal care in Nevada? And I wasn't able to identify any one place you could go to. There's definitely information on a lot of different websites, but you kind of have to know what you're looking for. And when you go into the websites, trying to figure out. So the suggestion we would make is to create a one-stop website for mothers so they could easily locate healthcare providers in their community, transportation assistance, insurance eligibility information, both commercial and Medicaid, and answers to some basic information about pregnancy. And we thought that if this website QR code was created, that could be put on postcards and in social media so that we could hand that out to people and have them in communities so that anybody who's interested in having this information could go on and find it very quickly. We also thought that a social media campaign was needed. I haven't seen too much in this area, but we know that a lot of young people are on social media all the time. So we need to go where they are to reach them and encourage healthy habits as well. So we put together a proposal that we submitted to you, kind of taking number 1 and number 2 and combining them and a few other aspects with it, and just appreciated that you would take some time and give some consideration to that. Third is with improving access. So, we've done a great job. There's more work to do on trying to encourage people to live and work in rural areas. And that is incredibly important. But I was thinking about it, I said, well, maybe we need to take it just from a little bit different angle. And that is, what could we create to encourage people and providers in urban areas to go out to the rural areas for 2 or 3 days a month? Right now, if they do that, they're going to lose a lot of money because they've got to drive out to the place, get everything set up. But if we could create a place for them to go and they received an enhanced reimbursement from Medicaid or from the state for going out there, if they drive 20 or 30 miles or more away from their office, they get this enhanced reimbursement rate. Could we attract more people to get out there so that we could provide better prenatal care services? So it's just something to think about. And finally, yes.
Last thing I wanted to say on that too is just give another plug for state Medicaid here. This is an area I know that they are actively working on and currently looking at how to unbundle some of those prenatal services from the bundled delivery rate. Now, that's something that is particularly of interest to the rural hospitals. I don't want to scare anybody. I know there's finance folks across the state that might have concerns about what that would do to their hospital, but that is something that Medicaid is evaluating. And so we're looking forward to seeing the results of that.
And that kind of goes into the fourth category here of supporting hospital capacity, because we always have workforce issues. It's gotten just a little bit better, but there's still a lot of work to do in getting the folks we need in the areas that we need them. And also, we're going to need improved Medicaid funding, given the cuts that are coming our way because of HR 1. So there are a lot of different issues out there. I just want you all to know that we're extremely grateful that you're focusing on this issue, because we know it's incredibly important and it's just something that's best for our families and our communities in the state. So thank you so much, and we'll be happy to answer any questions that you have.
Thank you so much, both of you, for taking the time to pull all that together. Just want to open it up to any of the commissioners. Are there questions? Looks like we have a hand.
Dr. Gleiman? Hey, Patrick?
Yes.
Dr. Gleiman, I wanted to thank the Hospital Association. You guys have been magnificent over the years in helping the Medicaid population in the state on a number of issues, and we are very grateful in this community. I just make a couple of comments. Number one, thank you, Renown, for starting the OB residency program. Just like we found here down in Las Vegas, a number of the residency programs bring in these great residents and then they leave the state because there's not a lot of incentive to stay here. That becomes problematic, and I think there should be somebody looking at who they're picking and where they may go afterwards and have incentives in that half. Second of all, as a person who's getting nailed by malpractice going through the roof, mine have tripled in a year with no incidents, and that is a significant problem that's going to drive people out of practice. I've been the chief of surgery and chief of staff at a big hospital here, and we're losing specialties left and right, not just in OB/GYN. And I think the root problem has to do with the paying system, and it's not Medicaid. It has to do with the way that Medicare is reimbursing physicians in this state relative to California, New York, and some of the other big states, because we're the lowest level of reimbursement. And I think that the insurance companies have to follow along. So that's a financial problem altogether. But I want to thank you for your agenda and your talk today. And I think some of these issues just all come down to payment, and you can't keep people working here. You pointed out for $300, what are you getting? I mean, in my own case, I can do a kid. I've trained in craniofacial surgery. If I take care of a young baby who's born with a craniosynostosis and his head is deformed, and I have to move all the bones of their skull and around their eyes around, I get paid $242 by Medicaid for that. Meanwhile, because I also have a dental license along with a medical license, if I take one tooth out, I get paid $400. So, the disparity in reimbursement for complex procedures is pushing people away from doing complex procedures, and that includes OB/GYN and other complex procedures. And I'm not sure that people are going to want to take those liability risks, and it's going to really be a disservice to our state when we're trying to attract businesses to come here. And education is part one, but you need good healthcare if you want to have industry come here. So it's a vicious cycle, and I think that it's difficult to get these things resolved.
Doctor, thank you for sharing that with us. And I'm sorry your malpractice premiums have tripled. That's extremely concerning.
Not my doing, but it is what it is. And I understand that is a reason, because the other issue that it's going up is unbeknown. It's not necessarily the trial lawyers, but what's going on is that these hedge funds have been buying up practices. And then on the other end, the hedge funds are then, and the VC people are pumping money to the trial lawyers so that they can support lawsuits against doctors and the clinics that they purchased. So it's like a scheme to jack up their reimbursement. So that's the other thing that we're seeing, and the reason that these rates are going up. So the insurance companies know that stuff. They're smart. They've done all the actuarial data, and that's part of the reason it's going up. It's not necessarily the trial lawyers in that bill that you guys passed in 23, where it went from 350 to 700. I mean, that is what it is. That's economics, and I understand that. But there's other things going on behind the scenes that are driving these costs up. So it's a big issue. These are all big issues, and I'm very fortunate to be on this commission working with some smart people. And this issue with maternal and child is great that we're working on, but these issues are all sort of tied together, and I think need to be looked at in a sort of a global way too. That's all I have to say. Thanks.
Dr. Glennon. Stacy.
Good morning. I just wanted to say thank you, Dr. Glyman. I just want to say it's the first time I've ever heard someone say it's not all Medicaid, so I kind of chuckle because I just want to have that moment on record. And then Pat, thank you, and to Blaine, both of you, for the presentation. It was really great. I think something we're seeing, and if Ann Jensen, the Medicaid director, was on this morning, she'd probably say the same. We did a rural hospital tour. We're doing one right now. We do it every 2 years. And since I started in this role, and it's been really helpful. And one of the things that we, again, time and time, see out in our rural communities around maternal health outcomes is the sort of the volume. And, it's really hard to have an OB out there without the volume. And what can we do to build a rate that really does support other types of providers, like a primary care, for example, to provide these services? I do want to just note that the thing that we're really thinking through on the Medicaid side, and I think it's in front of this committee, is do we unbundle some of the bundled rate, increase funding to things like prenatal care, postpartum care in that unbundling, so we can really reward and incentivize those systems that can invest in that space. Because right now, what's happening is these hospitals are not really, especially the ones that cannot get an OB to provide birth, they don't really get paid if they just did the prenatal care to support moms in their community. So how do we do that in a way where we can really support the maternal health, the full spectrum? So I just wanted to give you guys sort of that information. We heard it 2 years ago, and I know Anne mentioned to me the other day they heard it again. And it kind of just goes back to some of the work we're trying to do internally on looking at unbundling the rate and really putting the funding where we think it makes the most sense to incentivize our system and reward our providers that are doing that work. But again, thanks Pat and Blaine. I always appreciate hearing you guys' perspective, and Dr. Glyman for talking on the bigger picture, because it is something I think we all need to think through. It's not just rates. There's a lot going on in the healthcare system that are driving costs all over the board, across the board. So thank you.
I'd like to also thank Stacy for Medicaid, because quite frankly, Medicaid's not supposed to make people rich. It takes care of the people that are at the most risk in society. They are a great population, and I think the people who don't take Medicaid are really underserving themselves as doctors in terms of taking care of them, and you get the most rewarding experience taking it. So Medicaid has been great, and I don't think Medicaid is the issue, because the Medicaid reimbursement, while it may be bad for hospitals, it's not bad for the providers. I think the real issue is the Medicare component, and that's something that I really would hope that the governor and the legislature works on to get the rates at least commensurate with some of the states, because right now the cost of living in California in some ways is pretty close to Nevada. So people leave the residency here and go to California and make 5 times as much for the same procedure. So that's part of the reason we're losing a lot of the physicians here.
Yeah, great comments. And Stacy, thank you for that. I just wanted to take a second to kind of echo some of that and appreciate that your team is out doing the tour of our rural hospitals. I think a great point to make here is that your folks completed last week. We did the northern tour, and we've now finished our critical access hospitals that provide obstetrics and delivery services. And so the whole rest of the way, they won't see another critical access hospital that's able to provide those services currently. And so that's something we saw on the map that Pat showed earlier. You can see that where those services are located in the state. And now kind of this next trip in the south, you won't see any more of those hospitals. And then you made a great point as well, Stacey, about family practice providers as well. And wherever viable, we try to employ those family practice obstetricians as well to try to make those services available across the state.
Great dialogue this morning. I'll also open it up to Dr. Walker now.
Hi, thank you very much. And thank you to you both for your presentation. Piggybacking on what Stacy Weeks has mentioned, do you guys have any information you can share about how I believe it's the AMA and their proposed unbundling of the global obstetric codes is going to affect rural hospitals or hospitals in general providing labor and delivery services? And if you can give us some information on that. I know coding reform doesn't necessarily always equal payment reform, but I'm curious your thoughts.
Great question, Dr. Walker. Thank you. No, we're just going through that process right now and going to work with Medicaid on that. So more to come, but we don't have anything we could share right now. We're encouraged by some of the conversation around that and still looking at it.
And I'd have to ditto Blaine's comments.
And I just want to note that the next presentation on the agenda does start to talk a little bit about those AMA changes.
All right, Dr. Peterson.
Yeah, I just had a question on unbundling of those codes. Is that something that you need legislative approval for, or is that something that Medicaid can do without that?
Stacey, please chime in. Yeah.
Chair, thank you. I'm not sure if we're being formal or not here. So I'm coming on camera. We're in Vegas at a hotel. So yes, we do need some legislation. We need funding. I think having a recommendation from this committee would be very helpful. We're happy, I think, to have Ann Dillon come and talk through what we're working on with Milliman. But we're early, we're trying to fast but furious right now because we're building our budgets for session. So, one of the things that we were trying to think through, do we need more funding? Because we don't want to spread the bundled rate too thin and then not have an impact. So would love to bring some of that to this table, Dylan, and Bethany and Chair and others, if that's what the commission would like to see.
Okay, thank you.
Yeah, I think that would be really helpful because I think maybe I was misunderstanding some of the dialogue that we had previously had here, that sort of was already in the works. So if that's something that may need or be helped by a recommendation from us, or other components, I think we definitely should get even more educated on it. That would be great.
Can I ask one more question too, that kind of connects to it? Because I feel like we've heard a lot about the pregnancy health home model as well. Stacy, is that something also that I just want to clarify that would require legislative approval?
Yes. One of the reasons we like the model, mostly from a financial perspective, is we can get 90% federal funding to pay for it the first 2 years. So I think there could be a combination of both reforms next session pending funding. We're working on the budgets now. It's hard to know where we'll end up at the end in funding, but it could at least still be a recommendation from this committee, which helps other lawmakers pick it up. But it also could be an item for special consideration if we can't get it actually in the budget. But yeah, we can, we have Milliman on contract, Dylan. It might be worth talking to Ann to see if maybe Milliman can come and talk through pros and cons, because there are trade-offs on all these things. That we could get the commission's feedback on. I think that would be really valuable to us building this out.
Yeah,
And I think it would be helpful to, I was going to say, help to understand the financial impact, because we don't want to, hit you twice with if we're unbundling and recommending the pregnancy health home model, if that's going to carry such a large fiscal impact for you, it's not doable. So understanding the implications of those, I think, would be helpful for us.
Yeah, I think both are. Here's the deal. I think if we can argue fiscal impact gives us longer term savings and high risk pregnancy, because if we can really solve some of the prenatal care problems, it will help the cost of high risk pregnancy. Now, some of those things are bigger than just prenatal care. We know there's other social determinants of health, right, impacting families. And that's why I like the health home model, because it really brings in not just the care. It talks about coordinating services to support mom and baby, right? Or the pregnant mom, including social services and other housing needs and those types of things. So I think it could be a nice combo to really build out. And the nice thing about the health home model the first 2 years is it's really cheap. So it'd be a nice thing to put together. But Anne, she's probably going to get on to me later for bringing this up so soon, but I think it's something she would welcome feedback from this group on.
That's excellent. And is Milliman helping with some of that financial modeling and understanding the longer term impacts? Yeah, I think that would be great. So Dylan, maybe if we can make a note to figure out how we get that on one of our sessions, that would be excellent. And totally agree, Stacy, like the concept of it, especially if we can get funding early on, that sort of creates maybe longer term sustainability, because you start to see some of the impact flowing through. It's great.
Right. So after the first 2 years, maybe we're starting to see some savings. I see Jeremy Hayes on our team is on, so he probably can speak to some of that too. But if you pay for it, if it's cheap the first 2 years and then we're starting to see the savings, sometimes it can pay for some of itself. But again, it depends on take up, readiness of providers. The health home model, the cons of it are, it's a significant lift for providers. They really have to meet a lot of requirements and have the community health workers and nurses and others that can go into the community and work with families in the home and support, it's really a social services model. But we do think that some of our FQHCs are primed to do this and would be really good partners in this space.
Any other questions for Patrick or Blaine before we move to the next? Really appreciate the comprehensive view that you guys provided today. And again, always the time and energy that it takes to get prepared for coming to something like this. So thanks for that and the robust dialogue here.
Thank you very much, and keep up the great work.
Thank you all.
All right, we will continue to move forward. And up next, I think we have the Perinatal Health Payment Reform Overview and Opportunities. And Jeremy Hayes, I believe from Milliman, is going to join us on that one. Does that sound right? Jeremy, are you on the line?
Jeremy and Milliman.
So
Jeremy
my name
and
is Jeremy
Milliman, sorry.
Hayes. My name is Jeremy Hayes. I'm the chief of rates for Nevada Medicaid. First, I want to say thanks, Dylan, for bringing us onto the agenda here, and then thank you to Patrick and Blaine for teeing up this presentation so perfectly, and to Director Weeks for the kind of the preview of coming attractions. Oh, we got an echo. All right.
Should be good.
So I'm joined today by our partners at Milliman, who are supporting us in this work. So just a quick, run through the agenda. We're going to do the overview of the NVHA maternity payment strategy approach. We're going to be looking at those AMA changes to the CPT codes, look at the maternity care payment incentives state scan, and then, we'll solicit any feedback that you all have for us. Go to the next slide. All right. So taking a look at the roadmap for what we're doing with the maternity care work, our goal here is pretty straightforward, right? We want to ensure that our payment structures actually support the high quality, comprehensive care that we're asking our providers to deliver to our members. To do that, we've broken our strategy into immediate priorities and then more long-term goals. So looking at the short term, our focus is really on reimbursement review, basically a deep dive into the financial mechanics of, how care is delivered today. First, we're evaluating how we reimburse freestanding birth centers. A big part of what that is looking at like transfer payments to ensure that when a patient needs to move from like a birthing center to a hospital, that the financial side of that transaction is relatively seamless and fair to everybody. From there, beyond those facilities, we're looking closely at professional billing. We're assessing payment rates across the entire spectrum, antepartum, delivery, and postpartum. Two big things to note here. We're exploring enhanced payments specifically to incentivize those critical prenatal and postpartum visits. We're also preparing for the major shift in the CPT coding methodologies. We're working to incorporate those changes now so that our providers aren't caught off guard when the one-size-fits-all bundle transitions into more granular billing. And obviously, we're not going to implement that until 1/1/27, but we're going to be ready. Looking at the long term, really what we're doing, the goal is to move away from the pure fee-for-service. We want to develop alternative payment models that reward the outcomes rather than just the volume, right? It's not going to be a set it and forget it project though. We're going to be monitoring maternal health outcomes and utilization rates over the long haul. If the data shows us that certain areas we, still need a boost or anything like that, we'll have the framework in place to pivot and make those adjustments. Finally, underpinning this entire slide, and honestly every decision that we make is the data analysis that goes into support that decision making, right? We're not making these changes in a vacuum. And so, everything from rate adjustments to the APM design is being driven by our program specific data to ensure that these redesigns actually work for our state's unique population. And with that, I believe I'm handing it off to our Milliman partners.
That's right.
For the next slide.
Thanks, Jeremy. My name is Gwen Volk. I'm a principal and senior healthcare consultant at Milliman, and I'm joined here by Christine Bredfeld, who is a senior healthcare consultant also here at Milliman. And we're going to go through a little bit about the AMA unbundling, sort of talk through what that looks like. Some of you may be very familiar with it. Some of you may not have had as much time to pay attention to it yet. So we're going to take some time to walk through that and then go through some of the an initial sort of state scan of different types of payment rate incentives that have been used for both prenatal care and postpartum care, and then would love to field questions and feedback afterwards. So I'm going to turn this over to Christine, who's going to talk a little bit to the unbundling.
Thank you, Gwen. There we go. Next slide. All right. So as many of you know, the AMA, and as you've heard, the AMA is restructuring the current maternity care service codes. So on March 2nd, they had a webinar going into the changes that are upcoming. The primary change is the deletion of all global and bundled codes for maternity care. They will be replaced by service-specific billing. So the billing will get much more granular. As you've heard, those updates are going to take effect January 1st of 2027. CMS is currently in the process of setting the relative values for those new codes, and the proposed values will be published in July of this year, and then final values and weights will be published in November. So NVHA is planning to transition to the updated codes on January 1st. The rates for antepartum delivery and postpartum visits are currently being assessed, so more to come on that. So I'm going to talk just a little bit about the structure of the new codes. If we can go to the next slide, please. So the AMA's restructuring of the codes identifies 4 maternity care phases. So this is in contrast a little bit to what they had before, which is the antepartum, the delivery, and the postpartum periods. They're now going to be looking at antepartum, labor management, delivery, and postpartum care. So for antepartum care, the global billing for prenatal visits is going away, and people will be asked to code prenatal care visits entirely with evaluation and management codes with the TH modifier. There is going to be a separate codes for normal and abnormal pregnancy. So if you provide more than the 7+ visits in the global billing, you will be reimbursed for every visit that you provide. The labor management then is no longer going to be included in the full global maternity care or in the delivery codes. It's going to be billed separately. So it's actually going to be, there will be different codes for straightforward and complex labor, and then also for initial and subsequent days. So this is getting much more granular. And then delivery care will be billed separately. And there are different delivery codes for each service provider type. And then different delivery codes for cesarean and vaginal deliveries, looking at complicated and uncomplicated deliveries. Then for postpartum care, though, like the prenatal visits, those will be coded using evaluation and management codes, and there will be varying levels of coding based on the visit duration and complexity. So if we can go to the next slide. Just a little bit of an overview of the codes that are being discontinued. These are all the global or bundled codes that are being used today. For example, the vaginal delivery only code that is being unbundled into the labor management and delivery separately. I'm not going to go through all of these codes in detail. I think many of you are familiar with them, and you also have the slides, I believe, so you can look at these codes in more detail. If you go to the next slide, we'll talk a little bit about what codes are being added. So as you can see here, I mentioned that the codes are getting much more granular for labor management and delivery care. You can see that for labor management, you've got 4 codes now, separating it into straightforward and complex, and first day and subsequent days. And then for delivery care, you've got separate codes for vaginal and cesarean, which go into whether it is after the vaginal delivery is after a previous cesarean, and then whether there are repairs of various degrees of laceration. And then for cesarean delivery, there are 3 codes that go into whether it's an initial or a repeat cesarean, and whether there is a hysterectomy after the cesarean delivery. And then for postpartum care, there's also going to be a new code for uterine tamponade. So that's a quick overview of the new codes. Again, you can review these new codes in in the deck that was provided. And if you go to the next slide, that tees us up for Gwen to cover the payment incentive state scan.
Excellent. Thanks, Christine. So we did an initial state scan. You can see the states included in the research sort of listed in the right, looking for different ways that state Medicaid programs, either through fee-for-service or managed care, were incentivizing maternity care service delivery and outcomes, really notably around prenatal care, postpartum care, and assessments. And so you can see here that on the slide that we're showing, we kind of saw them in two different buckets. The first bucket is provider incentives, and the second bucket is patient incentives. So on the provider incentives, we're going to kind of walk through both of these categories a little bit more, but a little bit more of an emphasis on the provider incentives. The provider incentives can include sort of one-time payments or uniform rate increases or payments for reaching a certain specific amount of, for example, prenatal visits. And the patient incentives are sort of structured similar to the provider incentives in terms of generally emphasizing the attendance at prenatal and postpartum visits. And they include things like monetary gift cards or one-time payments or gifted items like a baby carrier. These patient incentives are really able to be done in Medicaid programs through the managed care plans. So the focus for a state is often on the provider incentives in terms of what can be required by the state. So we're going to go and sort of show specific examples of both of these to provide more context. So I think we're going to steal the screen to share that attachment A. Here we go. All right, and so, and I think Christine will blow this up just a little bit more so we can maybe see a little bit more on screen here. So we have two parts of this attachment. The first part is the provider incentives. The second part is patient incentives. So I'm going to go through the provider incentives first, and you can really pretty quickly start to get a flavor of what is seen here. And so starting at the top, so these are, the first table are initiatives specific to the state Medicaid agencies as opposed to something that's been identified as being paid out through a Medicaid managed care plan. So for North Carolina, you have one-time payments for standardized risk screening, for postpartum visits within 60 days, and for group prenatal care, sort of on or after the 5th group session. So definitely emphasizing continued attendance. You can see those incentives range from that $50 for that standardized risk screening to $150 for that postpartum visit within 60 days, then to $250 for that group prenatal care participation. Illinois has two one-time payments that are made to providers specific to postpartum visits. They're $75. One is made for a postpartum visit within 26 days, and another one is made for a visit between days 27 to 89. Texas has a uniform rate increase for prenatal visits, postpartum office visits, and then pregnancy-related outpatient E&M services. That amount is unspecified, but there was sort of an overall bump that applied to those services. And then in Mississippi, they have a sort of one-time payment of $250. It can be paid out for either a post-delivery risk assessment or postpartum visits that are completed within the post-delivery risk assessment specified time frame. So you can kind of see here that we've got that mix of prenatal and postpartum visits that are being incentivized, and sometimes some kind of standardized risk screening as well. And so if we scroll down just a little bit to see the managed care organization initiatives, they're very similar here. You can see sort of one-time payments for a prenatal or postpartum assessment form, for example, through Health Partners plans in Pennsylvania. AmeriHealth Caritas has a payment for initial prenatal visit, subsequent prenatal care, postpartum care visit, as well as a postpartum depression screening. So that's a very specific screening for postpartum that they attach that one-time payment to. In South Carolina, you have Healthy Blue, their Blue Choice Health Plan, doing a one-time payment for the notification of pregnancy that's submitted within 7 business days from diagnosis date. And then you have up to 10 payments of $30 each for what is called centering pregnancy visits. And that's a prenatal model of care where you have individuals who are pregnant who attend sort of group prenatal visits. And then for Tennessee, there's a one-time payment for 2 postpartum visits within the 4th trimester or postpartum period. And then for North Carolina, there's a one-time payment for completing a risk screening tool, and then also a one-time payment for a postpartum visit within 60 days of delivery per Medicaid recipient. So you can obviously see there's a very obvious trend in terms of types of payment rate incentives that are being paid out to providers, encompassing both those prenatal and postpartum visits, some screenings or risk assessments, and then you have some sort of more unique payments that are associated with that reporting of pregnancy, of notification of pregnancy, or a specific kind of model of care like the centering pregnancy visits. And then on the next tab over, you'll see patient incentives. We won't spend quite as much time on these because they are more unique to each managed care plan and what the managed care plan chooses to do. But they are similar in terms of incentivizing prenatal or postpartum visits. You can see in New Mexico, there's sort of a welcome gift for completing the first home visit. There's what New Mexico sort of has in their Turquoise Care Medical Home Visiting Rewards Program has rewards points that can be then redeemed for items on an online score, and you can get those points for joining in your first semester or second trimester or any other time. And then you can see in Illinois, Molina's using Walmart gift cards for different prenatal and postpartum visits. North Carolina, Healthy Blue North Carolina, and Carolina Complete Health are also doing either a gift card or a one-time payment for visits or notification of pregnancy. And then that same sort of trend echoing down through West Virginia's Aetna Better Health, Missouri's Healthy Blue, Missouri, and Mississippi's Molina Healthcare. So that is generally the trends we're seeing. We certainly, maybe if we go back to the overall presentation, we are curious as to, approaches that you may have seen along this vein in other states or that you're aware of that you think are particularly helpful or useful. We'd love to hear about them and add to this sort of scan. So just sort of stepping back, opening it up for questions and feedback. Certainly some of the ones we're sort of teeing up here to help with discussion of, are there specific barriers in terms of reimbursement or billing or access or other areas that the state should be aware of as they develop rate options? And are there specific models locally, or from other states that are of particular interest? Or any other feedback or questions? And Jeremy, anything else you'd like to add here to tee up the feedback and questions on this part?
No, that was perfect. Yeah, we would definitely like any feedback from the PPC. I feel like we have a very authoritative group when it comes to what we're trying to accomplish here, and so soliciting your feedback, especially on these first 2 questions, would be phenomenal.
I will open it up to commissioners. I think you guys were on and heard the dialogue around some of the rural providers and family practitioners who may be in those rural environments and can likely access or provide a lot of that prenatal care, but may not end up doing the delivery and those sorts of things. And how do we make sure that the right models for reimbursement are in place? And I think as you went through the unbundling, it seems like that would certainly be a methodology that would help that scenario, but those comments were in some of the previous presentations. So I'll stop there. Are there other folks? Dr. Peterson?
Yeah, mine is just more around screening. I saw like the postpartum depression, but just making sure like perinatal mood and anxiety disorder, screening for substance use is really important. Our number one cause of death in the state of Nevada for pregnancy associated death is overdose. So just making sure that we're capturing all that perinatal mood and anxiety disorder screening tools.
Yeah, and I will say, I know that someone touched on the maternal health home. We are in the middle of the analysis for that, hoping to stand that up, I believe by 1/1/27. So yeah, we're definitely keeping that in mind.
So, Dr. Porath?
Just wondering if you've seen models that were maybe a little bit more granular as far as like incentivizing prescription of prenatal vitamins, ensuring prenatal vaccination status, that sort of thing.
We did not see that in the state scan that we did, but we certainly can keep our eye out on that. And, and even so, not seeing it in other states doesn't mean that it isn't something that the state, couldn't consider. Do you mind running through that list one more time? Apologies that you mentioned.
Oh, I prescription of prenatal vitamins, and then prenatal vaccination status.
Mm-hmm. Okay.
I love that, Adam. Actually thinking about it more from a prenatal perspective, a lot of those incentives are around some of the follow-up care and other things, but I think getting in front of that's a nice idea. Other input at this point? Okay, thank you. I know you probably heard us also say that maybe we can have some more dialogue about the maternal home model, and so perhaps we will see you all again for that dialogue. Thank you again for the presentation. A lot of great information and insights there, and I certainly always love seeing what nifty ideas are in other states and thinking about, maybe we don't have to create something from scratch. What could we pull in terms of great ideas? So thank you for bringing that forward as well.
Yeah, thank you so much for having us.
Awesome. I did want to loop back and just mention that we had skipped an item on the agenda, which was around potential announcement of additional commissioners, and we skipped that because there were no additional commissioners to introduce or share today. So just wanted to note that that was a purposeful skip over that item on the agenda, and certainly we'll do that in future agendas if we need to and if there are additional commissioners. Let us continue forward. So I think we now are on item number 7, which is some of the policy recommendations that we would love for the commission to review today. And I think, Dylan, you're going to tee us up on this first, yeah?
Yep.
Great.
So quickly, I just want to contextualize where or how we got to this point. So commissioners to this point have heard from, I think, over 11 presentations across the healthcare landscape, including state public health experts, clinicians, workforce and rural health experts, NBHA leadership, hospital system representatives, and national policy groups, as well as reviewing numerous studies and data presentations. And from that process, we've gathered 58 unique policy submissions from the public forum and recommendations raised during public meetings. And our meeting cadence and the framework is kind of largely based off of the steps to effective decision making, and the commission is moving into steps 3 and 4 through this review of policy proposals. So over the next few months and beginning today, we're kind of kicking off this BDR development process and reviewing our work to date. And following the meeting today, commissioners will be asked to submit BDR concepts for consideration based on the policy proposals that we've received. The next meeting will be on May 22nd, and that's intended to review those BDR concepts and hold structured discussions around those. And then the June 12th meeting being a continuation of that, including BDR discussion and a vote on those top 3 BDR topics. Commissioners are going to need to approve the intent of those 3 BDR topics, and staff will draft and submit to LCB prior to the September 1st deadline. There is time built in prior to that deadline for additional meetings as needed, but we would like to get something in by that June 12th meeting date. So far through public input and presentations, we've received 58 unique policy options grouped across 7 different problem areas. These include coverage and benefits, health literacy, payment reform, population health, behavioral health, rural health, workforce capacity, and training. And within each of these categories, they're further described in the problem sheets and available on the Commission's website, a high-level summary of the overall problem definition that we identified and the policy options that were recommended and address those areas. These policies and those descriptions are intended to give a snapshot to support the decision-making process. And we can prepare additional information as policies are narrowed and more additional information is needed. So within coverage and benefits, proposals included coverage expansions such as coverage for group prenatal care, dyadic interventions, home visiting, prenatal education, and unbundling of certain services such as screening for behavioral health conditions or postpartum long-acting reversible contraceptives, and enhanced perinatal support such as lactation support. In health literacy, proposals included improving navigation and transparency and access of information, as well as educational support and transparency, such as levels of prenatal care or birthing-friendly hospital designations. Payment reform included structural billing updates, such as unbundling that we heard before, or increasing or assessing payment rates for certain services or facilities, and alternative payment models like the pregnancy medical homes. Within population health, these proposals included things such as establishing a perinatal quality collaborative, adopting the Alliance for Innovation in Maternal Health, the AIM patient safety bundles, developing care coordination and other supports for vulnerable populations, among others. Behavioral health included recommendations to better integrate behavioral health into perinatal care, including increasing screening rates by unbundling those services, establishing pregnancy health home models for specific subpopulations like women with substance use disorder, adopting those patient safety bundles and other national best practices. Rural health includes expanding access and readiness to care for moms and babies in rural or under-resourced settings, such as expanding infrastructure, including things like ultrasound and other diagnostic equipment, as well as telehealth technology and better enabling the use of telehealth in those rural communities when it's appropriate. And then finally, the workforce capacity and training component, which includes continuing education and telehealth to optimize the existing workforce and consider other strategies to increase the workforce supply through training or licensure expansion. Several of these policies are cross-cutting, so you may see them in multiple problem sheets. And given the kind of the large body of the policy proposals that we have received and the timeline for reviewing them, I would propose the following framework as commissioners are evaluating and considering these policies. First being for BDR consideration and possible decision criteria could include that it has a strong evidence base and requires statutory change, has high impact and reasonable feasibility, or would likely not be implemented or not feasible without a BDR. The next category being formal recommendations by the PPC. These would be included in our semi-annual report due on January 1st and could be potential BDRs another entity could carry, and evidence supports the action, but for whatever reason did not make it as a BDR topic for the PPC. That next category being similar category, so programmatic recommendations. These are achievable without legislation and in clear alignment with a current program or authority, such as recommendations to the Rural Health Transformation Program, the SHARP grant program, value-based care, Medicaid, the exchange, and then DHS or MBHA. And then possible future recommendations. These might just need more time for analysis, but merit consideration. They may lack the authority, stakeholder buy-in, or readiness and just not feasible yet. Some actions could be recommendations of a work group or study, or just for future consideration by the PPC. These middle three areas are tentatively the topic following this BDR process to gather additional information and develop those formal recommendations. And then finally, policies to no longer consider. These policies don't have sufficient evidence, are out of scope, or commissioners feel should not advance. Given all of this, do any commissioners have any questions or comments? Otherwise, I'll hand it off to Chair Sexton to facilitate the discussion.
Maybe I'll just ask one clarifying question, Dylan. So I think if we put something in the category for BDR consideration, we will work through that and really develop that out for further conversations in some of the upcoming meetings that we have and the like, and that will have support from staff and others to help us get what we need to really develop that out. That's right. And then the three in the middle, we're saying those, you know, may also come at a little bit later date in terms of how we want to formalize what we would put forward for either a formal recommendation or programmatic recommendation later, a little bit later into our process. Is that accurate?
Yes. Yes.
Thank you. Any other questions on how we've kind of teed up the framework here? Again, there's a lot of ideas. I'm very hopeful that commissioners have had the opportunity to look through some of the materials provided, because there's a lot of detail and a lot of amazing work went into summarizing some pretty complex topics and distilling them down to some of the key themes and opportunities. Okay, hearing none, let's keep moving forward. So this is the part of the agenda where I'm hoping we will have a lot of interaction, a lot of dialogue, and would love if folks are available to come on camera at this point. I think it would be great just so that we're engaged and we maybe don't necessarily have to go with hands up and other things. We can have more of an open dialogue here. I think I just want to reference a couple of materials that were in the provided packet. If you want to, I think it would probably be ideal to open up the policy proposals Excel spreadsheet. That I think is probably the easiest to sort of search through quickly if you want to reference to line items. And also Dylan and others, I don't know exactly who all prepared it. Maybe it was you, Dylan, did an awesome what we're calling action priority matrix. And I don't know, do you have that slide for us? Let's maybe go there real quick if we can. What we tried to do is think about some of the level of effort that might be needed in order to accomplish some of these items, and also the broader impact. And so obviously probably many of you are familiar with this type of a 4-box matrix that helps us to kind of hone in on where we might want to focus some of our efforts. But that green box really is indicating that at least on initial pass evaluation, those items really have potentially a strong impact and maybe pretty reasonable effort in order to actually get them accomplished. And so would love your guys' thoughts about, I think we have 3 BDRs. And so if we're going to use them and spend them, so to speak, on any of these items, I know at least from having going through the last legislative session, would really like our BDRs to make it forward and actually have some impact. And so I think if we can at least maybe think about a couple of BDRs coming out of some of that green area, and then maybe there's a little bit longer shot type BDR that we want to focus on, something that may take a little bit more effort, but we feel like we could put together a really strong proposal. Then I think going into that blue box in terms of some of the items might be a reasonable thought, but it would open it up for any dialogue around how we want to at least start to focus and where we might want to start the conversation on some of these items. Again, this is the open dialogue part. Dr. Peterson. And please, you guys, feel
Can I
free,
just-
let's have open dialogue here if we can.
I just want to circle back to one thing on the NICU because I think it's come up a couple of times, and I know that Dr. Erie presented last time, but just kind of wanted to like highlight one thing where this is like maternal infant. And so I actually went back to his slides just kind of so it's fresh for us a little bit. And that is kind of like the questions around the level 3 NICUs. And Patrick did a nice job of kind of highlighting how many we have where. So specifically in Clark County, we have 8 of 9 hospitals that have a level 3 or greater. And so kind of like questions, is that something that's good? Is that something that, maybe isn't so good? And so I think it's having an impact potentially on some of the outcomes. So he has a slide that says hospitals treating less than 100 very low birth weight babies have significantly higher mortality rates, looking at around 5.4 times higher. And so he cited in 2023, there was 445 very low birth weight infants. And so if you're not familiar, that's going to be like your premature infants that are weighing like less than 1,500 grams. So 340 were in Clark County. So if you split those 340 births between the 8 NICUs, which again, they wouldn't all be level, but if we just split them, each NICU there's only seen around 42 per unit. And so again, they really need to see around, a higher number than that to be able to be proficient. So I just wanted to go back to kind of like that NICU discussion and maybe highlight, just some of the thought is around regionalization. So just making sure that we're all on the same page with that. So it's kind of, in my mind, it's like, how do we help these labor and delivery units ensure that they're able to provide the services and that they're sustainable, but also making sure that we're getting, evidence-based care in our NICUs and for our neonates and our infants. So I just wanted to make sure that we kind of went back to that, that conversation, because I know it's a little bit complicated.
Thank you for highlighting that. And I think in the policy proposals, I believe, so check me on this, Dylan, that was line item number 35, the NICU regionalization, excuse me. And so again, based on initial assessment, there's probably more to be done there if that was something we wanted to consider doing a deep dive on, seeming like the level of effort may be fairly high and decent impact too. But so would definitely put that on the radar in terms of where at least it's kind of sitting on this matrix now.
And then I do have one other question, sorry. Would it be possible to bundle 2 items together? So we're looking at something like unbundling the obstetric codes and the pregnancy health home. Would it be possible to combine those if we were looking at like a BDR recommendation?
My understanding is that we have single topic BDRs. If they're the same topic, I think we were able to bundle them together. But I'll defer to our DAG that's on the meeting if he's able to provide any clarification there. And if Jose is not able to come up, we can get you an answer to that question after the meeting.
Okay.
Yeah, and I think maybe more specifically, like, what does it mean topic? Because you could consider the topic there is like reimbursement methodology, and then you have sort of multiple categories under that. But I think that would be helpful as we
and I think a lot of these BDR or topics do fit nicely together. So that is something that we should consider.
I think line or 57 is just kind of a more generic unbundling. Might be one to consider.
Yep, I had that highlighted as well. And I think we will need to get a little bit more clarity around, does that have to be a BDR? Should that be a recommendation? But at least maybe we keep that one on the list. So I guess I would offer up to the broader group, like, would we be comfortable at least keeping that on the list for further evaluation? And then maybe in a follow-up meeting, we can get really clear on what category we need to put it in. Seeing some head nods. Any other folks, Dr. Walker or others who may be on the line still?
Yeah. No, I think for me, I think one of the priorities that I took out of this, and I apologize for the background. I think finance reform is going to be a big issue that we need to address, but one of my priorities is also the workforce. I think that just focusing on broad areas of policy that have been addressed, that if we're able to address the prenatal workforce, I think one, to address the what was presented today, the aging OBGYN population, the limited supply of obstetric providers that we have, whether they be physicians or midwives or so on. I think that looking at line item, oh gosh, where was it? When we were talking about rural residencies and training tracks, the better ability we have to train people in the state, my feeling and experience has been the more likely we have an ability to keep them in the state. And I think we could probably work, I think it's line item 50 and 51. They seem to be very similar into a BDR, but in my mind, major frameworks would be workforce development and payment reform, and how we can kind of build capacity, supply of providers, hopefully upstream at the prenatal level, so we don't have to depend on enhanced NICU services, but then also how do we create stability for that increasing supply of providers?
Awesome. Thank you, Dr. Walker, for the input there. And it sounds like you have a dog just like mine, so I can fully appreciate the challenge.
One thing I wanted to call out was 42. We talked a lot about the prenatal quality collaborative. I see it's rated as a higher level of effort here, but I think that as far as the level of impact, obviously, I think would be really high there if we were able to operationalize that. So,
can I ask a question on? Oh, sorry.
I was just saying I agree.
I was just gonna ask on 42. I know that there was an extensive presentation at Interim Health on that as well. Like, is there a way for us to understand other efforts?
We can ask Interim Health. It's my understanding that they may be pursuing that as a policy option.
So maybe we could even make that as a recommendation if we know that they are already pursuing that.
Mm-hmm.
I like the idea of keeping that one on the list too. That was one of my top as I went through, because I think, the more you have some of that data, more actionable you can get. But if somebody else is taking it forward, then just throwing our support might be the way to go there.
I did just want to, one other thing, Dr. Peterson mentioned the behavioral health screening, and whether that be incentivization or whatever. I think that that's some form or fashion should be a high priority.
Was there a specific line item around that you guys were honing in on?
I think 36 or 39 maybe.
Yeah, to say it was there somewhere.
Okay, so 39 was perinatal behavioral health screening and follow-up. And then 40 was perinatal behavioral health strategic plan.
I'm wondering if that could somehow be in with the payment. And that might just be getting too big, if we're including too many things, making it too complicated. But I'm wondering if the screening, to me, that's kind of goes with if you're unbundling. Would that be allowed?
Yeah. If you look at there's an example of legislation from Iowa and Arkansas in the payment reform document, and those have multiple areas of payment reform, including unbundling of certain services that they specify in there. But I would point you to that document.
So that screening could potentially go in with the recommendation with the unbundling.
That's good. So we'll add that one to the list for further evaluation. Do we have, let's see, I'm just going to go down the list here. Is Dr. Glyman still on the line? It's a little bit tricky for me to doing it off my laptop today here. looks like maybe he had to drop. And then Dr. Khan, are you still on the line? Any input? Maybe he had to drop too.
No,
Dr.
I'm on
Khan's
the
here.
line.
Oh, thank you. Any thoughts or input?
Generally speaking, if it's okay, Madam Chairperson, what Dr. Glyman talked about, the perinatal natal hospital association presentation, etc. The challenge we have had over the decades, literally, and I've mentioned this before in our commission meetings in the past, which has really not come to any solution or resolution. So it keeps being discussed in various commissions and boards that the governor appoints. Talking about access to natal care, perinatal care, has been a challenge. My concern is each commission and board, and I know firsthand because I served in some way back, we talked about access and money, access and money, access and money. And that has not gone anywhere, literally. And we are still talking about this literally almost 30 years later. There was a commission set up by Kenny Gwynn. There was a commission set up before that. Barbara O'Connor, which set up federal issues. What can we really do to make a difference? The governor, in one of his letters when he took office, had sent us to me as chairperson that he was concerned about the reimbursement, Medicaid. Stacey has done a great job, very accessible, very reachable. But it all boils down to what can we do for compensation for the providers, be it physicians, hospitals, rural areas. That needle is not moving. So I'm afraid we'll do the same, go through the motions. And I guess that's all we can do. Send a BDR with all that concern and express our opinions. Is there any thought from our commission members, what can be done differently so it actually happens? We'll send another report, we'll send another BDR, and then the legislature will deliberate and it'll go nowhere. I mean, literally for 30 years, and I know a lot of that firsthand, so it becomes very frustrating for those of us who serve on these commissions voluntarily to not be able to impact. Now, we cannot as a commission lobby the legislature. We as individuals can certainly go and present our views when it is being debated. But what does happen is the other stakeholders are there in big strength who are not necessarily very interested in what we present, and things get blown over. So I'm just throwing it out there because this is something where the needle hasn't moved. My view has always been when we need money for issues like education or whatever else, we create billions of dollars one way or the other, whether it is smoking tax or casino tax or whatever. When it comes to healthcare, which is the number one concern, or should be our number one concern in the state, if we cannot move the needle for 30 years, I'm just interested in knowing what the commissioners think. What can we do differently?
Dr. Khan, thank you. I think you're saying what a lot of folks feel out loud, and I appreciate you bringing that forward because it does sometimes feel like we're banging our head against the wall a bit. I do want to just say that I feel like there are a number of things here that are fairly creative in their thinking. I mean, even the dialogue that Stacey, I think, shared earlier around some of the unbundling and thinking about how do we not just necessarily spread that money out and then it's just less in some areas and, happen to be a little bit more in other areas, but also how do we think about increasing the pie? I love the notion on the medical home or maternal medical home that there may be some additional funding that we could actually bring to bear to get some of these things moving forward. So then maybe it boils down to a little less of a fight in terms of long-term funding and things like that people, it's in some ways a zero-sum game that people are having to allocate. So thoughts from others on that?
I think is there opportunity to collaborate with other committees? Like I know the interim health has had some really great presentations. So is there opportunities, if we're headed in the same direction or if we kind of have the same thoughts, I think that would reflect positively. I don't know what that looks like because I've never done that in like a committee with PPC. But I think that could be something helpful.
We can certainly have that dialogue.
Can I
this comes
also
down-
just add, go.
Sorry, I was just going to say it all comes down to priorities, what we talked about. And I think that, the governor and the state, if they want to be successful and diversify away from the casino industry, not that we should, but we need other industry here to support our economic base. And you cannot get that other economic base without having good healthcare. If you look at the two things that drive people to move to states and what has been our problem in the state for years is, besides the prostitution issue, which is a separate issue, it's healthcare education, and we rank last or near last in all of these things. And unless we prioritize that we have to get this system better, it's not going to get better. So the tourism, the business councils, all these other things I have to understand. You're not going to bring big industry here unless we have good education, which is a priority, and good healthcare. And the Medicaid is a separate component of that. The other component is getting good doctors and good institutions here, and you need the money to pay people to do that. The hospitals will get reimbursed because they have a better lobby than most of the physicians and the other second tier providers. But we really need to work together to try and get more doctors who want to come here. And it all comes down to economics. If you're going to get paid reasonably, I'm not saying doctors are underpaid because that's a separate issue because doctors are well compensated. But when you're more well compensated elsewhere and the quality of life is equivalent, you're not going to come to an area like this. And that's the biggest problem that we have here. So it's a difficult issue, and I understand all of the concerns, which are very legitimate. But as Dr. Khan says, he's been here longer than me, and he's seen it all. And we just keep talking about a lot of these things, but we're not getting a lot of the traction that we need. And years ago, when I first came to town, the economy was you could buy a house, you could live here cheap, and it was a tenth of living in California. Now they're fairly equivalent, and that's why the vacuum is drawing doctors away from here. And all the residents that we're training at all the programs that I'm involved with, all these residency programs, a large percentage of these people we're training in the state are leaving. And it's a problem because we're paying money to have them stay here, and then they just leave. And that's the other problem.
Yeah, I appreciate all those thoughts, and I would suggest that we consider also, as we're looking at these policy options, the different policy levers that are available as well. It's not only the BDRs, but recommendations to rural health transformation, to graduate medical education, to the SHARP program, and how all of those things can kind of supplement what we're proposing for a BDR as well.
Like that. Also, Dr. Gleiman, when you were talking there, it made me think, because I really like the connection to the broader economic engine that I think so many are working to develop here in the state. And I'm just wondering if there might also be a voice from, I don't know, I'm thinking like NDOC, or I'm sorry, not NDOC, EDON, or others around, some of when they're trying to bring industry to the state, some of the barriers that they're running into from a very specific healthcare perspective. And if there's anything that we might gain from hearing from that voice as well, that we could, again, sort of build some of that momentum around what we're putting forward and the rationale
I've discussed
for it.
I've discussed this privately with the governor, and the governor understands this. He's really, I'm not being political at all, but he understands the broader implications of getting industry here. But there's political considerations in terms of dealing with a lot of these issues, and the political considerations are it costs money to pay for these programs. It costs money for Medicaid. It costs money for Medicare, and if you raise one, you lower somebody else's. So it's a difficult situation because the pot is only so big. But you can't grow the pot unless you have a tax base. and it's a vicious cycle. So sometimes you have to dig deep, get a bigger tax base, and go into debt for a little bit before you can then solve some of these other problems. So it's a big problem, and it's not that you don't have smart people like yourselves working on these things, because since I've been on this commission, I'm very impressed with how dedicated and how smart and how thoughtful people are, and the way that people are coming at it from different perspectives. I think, I've learned a lot being here. But from a person who's actually on the ground dealing with this stuff day to day and seeing what's going on in the hospital setting and in the industry setting, it's difficult. It's difficult, and I just see, what the effect of some of these policies are. So I appreciate everybody and their comments.
I'll just loop back to Dr. Glyman or Dr. Khan, any specific items on the list that we haven't already talked about that you want to call out? And then Dr. Walker will come back around to you.
I've said everything. Thanks. Appreciate it.
Yeah, my quick comment is I really believe that somehow, somewhere, for example, we are already 47, 49, 50th for 35, 40 years, even when reimbursement was supposedly better, but the population was smaller. There has got to be a mechanism where revenue can be generated, and that'll happen only if we declare healthcare access and care is a priority, if not an emergency. For the state, it has to come from top all the way into the legislature. And that's what I would like, because we have a very broad representation of various sectors in our commission. If we can somehow get the chief executive and the key people in the legislature to understand that this is the priority number one, we will not make progress, because all these decades, it has never been a major priority. Yes, we do homework and present reports, and they're all piled up. What can we do to make it that it's the number one priority? I think the more noise gets created, the more closer we get to creating a priority. There isn't enough noise from the medical community for obvious reasons.
Thank you for that. Okay, Dr. Walker, I see your hand up.
Yeah, I mean, just continuing with the conversation, I mean, obviously we have financial restrictions that are that many other states don't have or experience. And I think we need to keep that in mind strategically as we propose some of these. Going back to the spreadsheet, I like how the team put together really the priority matrix, and we have that column for action priorities. And looking at some of these quick wins, I had two questions. One, strategically for us as a commission, would it be beneficial to prioritize some of these as, hey, we know that we have limitations. If this is a low effort, hopefully low financial effort policy that we want to consider, is that something that we prioritize? But two, more of a clarifying question. Some of those quick wins in the action priority list, when you look over to like the expected impact and estimated cost, they're also listed as low, which seems a little counterintuitive to me. And I was wondering if somebody might be able to explain if there's a nuance that I'm missing there.
Dylan, do you want to talk a little bit about how the categories are evaluated?
Yeah, so for expected impact, we have the outcomes and the cost. And for a lot of the Medicaid costs, they're kind of ranked on what the Medicaid budget is. So, and Jeremy might be able to expand on this a little bit more, but it is rather large. It's a few $billion. So things in the tens of millions dollar range were categorized as low. And as we further assess these proposals, we can get more granular, but these are kind of our first pass through 58 policy proposals and categorizing them.
Okay. So just looking at that column, when we're saying expected impact, we're talking financial impact. Is that correct?
Impact being financial, but also thinking about outcomes as well.
Okay. Thank you.
Do you think it would be reasonable to narrow it down to those that are in the green so we can actually, like actually see what they look like to make sure that it is hitting? Because I do like how somebody mentioned workforce and payment reform seem to be kind of like the key
Top.
items. Yeah, so
Yep.
maybe if we look at those green to make sure that those are falling within that, and then we can eliminate from there. Like 44, I know, for example, says something around, oh, let me get back there a second.
Priority access.
Yeah, which I think is already required.
It's done for a certain class of hospitals. I'm not sure that it applies to all.
Okay, so it's expanding to all. Okay, I understand. Okay, so leaving it. Yeah, so I don't know if everybody would be open to that. Maybe we can have discussion around that. But if we narrowed it down to the green to see if it does look like those items are falling under what we've discussed today.
Yeah, so kind of the big buckets I've heard anyway are, to your point, workforce, payment reform kind of as a broad category. The other one that I heard was like, are there ways to actually generate revenue and create more specific funding? I like that idea of maybe thinking about all the ones in the green. Do we come back and see if any of those neatly fit into some of those bigger themes and what falls out? I guess the other question I might ask is like 42, I think was that perinatal quality collaborative, which I think we got a lot of kind of support for, but are there any other very specific ones that we might pull out of the darker blue that we want to just make sure either have a home somewhere else or we want to do a deeper dive on?
Lifting some from the earlier discussion, the health home model, which I believe may be, I don't remember the number, but that is categorized in the blue. Mom and baby home visiting is also categorized in the blue. Those are things that people have expressed support for in the past and maybe worth more consideration as well. But leave it open to commissioners.
That's interesting. How did that, I'm just wondering what made that go to the blue. Sorry. I was honestly assuming that the health home model.
It depends. I think it depends on the patient population. So if it's a broader patient population, I think there would be more effort needed to do that. If it's a focused population, like there is one specifically for substance use disorder, that might be a little bit more feasible in the near term versus building up capacity for a larger rollout.
I would propose then that we do add 18 to the list.
I would agree.
If we're going to look at the focus on the green for now. Would it be possible to almost take those that are in the blue and put them to the recommendation category right now? So that because it seems like those are still strong, ideas that.
Yeah, so maybe creating kind of the 3 categories ish and then laying them out and understanding within that what are some of the ones either that lump together and they're in the same topical area.
And we can,
yeah.
Sorry, we can create a sheet that has for BDR consideration and one being the quick wins and the other column being some that are high impact and high effort as well. And putting that in like a 2-column format.
Okay. And then is there any opposition to really culling off sort of the things that are really in that low impact, maybe still low effort, but more moderate effort, and just saying like, we only have so much bandwidth here. Are we good to let those go at this point?
I would agree with that.
Notes. Yeah.
I can also get behind that.
Okay. Is that, Dylan, do you feel like that is sufficient guidance for now to get us to the kind of next pass?
Yeah, and we'll release a survey after this meeting of BDR concepts, and that'll help staff figure out what you all want to focus on, and we can put together more information or different presenters that you all may want to hear from in the future. So I'd encourage you, please, to fill that out so that we can put that information together.
Yeah, and I will just double down on that and say, as chair, I would expect that we have 100% participation in the survey, please. So I'll be calling if we don't have your response yet. So
And I think if any recommendations can be made around things that could be bundled, that would be helpful so that we're, maximizing the recommendations that we're able to make. Bundle that can be feasible, because we don't want the bundle to make it so that it's not going to move forward also.
Yeah, this is Dr. Khan. Is Stacy still on the line?
She had to drop.
Oh, okay, that's fine.
If you have a question, I can get it to her.
Yeah, the only thing is that since she is very knowledgeable and an expert in Medicaid scenario as a whole, maybe she has some thoughts of her own how to sort of create revenue for the state, at least in that area. I don't know whether it's her area of domain or it becomes political, but it's worth asking her. She may have some thoughts. I mean, she is really an expert. We are very fortunate to have her. So maybe draw on her expertise if she's willing to share some thoughts as possibilities, then we can look at those when we are really deliberating finally on the BDRs as solutions, potential solutions.
Love that idea, Dr. Khan. Yeah. Okay. So I think if you feel like that's given enough support for sort of where, at least as an initial pass, we're heading to get some of these kind of honed in on, and then we'll do the survey, layer that on top. I think we'll continue forward. Yeah. Anything else, Dylan, that you want to make sure you get answered from commissioners?
Just this last question. If there's anything you want to raise before we kind of close this discussion that you feel hasn't gotten enough attention yet.
Yeah, I guess the one other thing I would say, Dr. Peterson, you did mention the NICU regionalization, so that I don't know exactly that fits in kind of those broader categories, but I think that's a good one to make sure we have.
I think it could still be a recommendation, like even if it's not something that's on a BDR. I think that's something that could definitely be a recommendation. Thank you.
And that may fit in the possible future recommendations as well. And we can put together more information.
One item that did just come to mind that I was thinking back to the presentations too, sorry, and I'm not sure if it's on the list or not, but the MMRC review process, I remember us discussing kind of like a significant lag time that is currently existing with that. So I don't know if there's a way, and that can be a recommendation as well. But a way to make a recommendation around having more of an expedited process, or that there's a process is completed within a specific amount of time. As I was just looking back at my notes, I had made a note about that too.
I will make a note.
Thank you. All right, last chance for today. Any others that we want to make sure either get more dialogue now or have more detailed pulled forward on them?
And I think it would be helpful for staff to just get feedback on what would be helpful for information that you all would like to have to make decisions. We put together the problem sheets to try to concisely put together a lot of information, but if you have any specific feedback on the information you want, please email me or if you want to just voice it now, but would appreciate that.
Let's just take maybe a minute or two on that. I mean, I think certainly the financial implications are important, and I think not just the whole dollar like kind of implications, but also to Dr. Khan's point, like, great, you can say this is going to cost a whole bunch of money, but how would we even get to it? You know, what are the considerations around funding sources and or, you know, sort of support more broadly, or mechanisms that could help offset those costs? I think that would be really helpful. Other things you guys would like to see as more of this is brought forward?
I think that'd be very helpful, especially kind of where we're saying with like the pregnancy health home model and kind of unbundling the codes if we're able to merge those together, but just want to make sure that that's something that could potentially be successful together.
The other thing I always do like to see too is the con, right? Meaning we're all excited about some of these things, but what are the unintended consequences, or what are the pieces that, you know, are going to be things that when we implement this typically there are implications. And so just want to make sure we're not sort of not considering those as well. I think that's helpful.
Barriers and unintended consequences. Okay.
Yep.
Yeah, because we haven't heard much from the OBs on their thoughts on unbundling.
Right. That's where it's like,
Yeah,
you pull one lever and is there a different unintended consequence that maybe we're just not fully considering?
yeah.
And is there, like, are there greater administrative burdens that might play out, or I don't know. I think some of those things
Feasibility to implement.
Yeah. And not only from, I'll say maybe some of our agency things, like when we're thinking about, can Medicaid really do this or not, but also from the end user perspective, like there's sometimes billing implications, there's staffing implications where maybe you have to all of a sudden do more administrative work or functions too. So I think trying to have a holistic picture of some of that is really helpful.
Okay.
Yeah. I'm trying to think, is there a statewide ACOG organization representing the OBs?
So.
Yeah, I'm just wondering if we could maybe engage them to determine to get their thoughts on that unbundling.
I think there's also a statewide medical group management association that focuses particularly on the operations and business. And perhaps there's some OB practices operators that can speak really to the financial implications of how that would. My assumption would be that the unbundling in general is going to be beneficial to patients who are getting fragmented care, high acuity care, but for those really high efficient OB practices, this could potentially be a hit to them.
And then, if others have come up with things along the way, please make sure that we're getting those to Dylan so that those can be incorporated. Okay. Awesome. All right. Does that bring us to the public comment period? So let's go ahead and do that now.
That moves us on to public comment.
One second, Dr. Khan. I must say today's discussion, I think, was very productive in the sense we sort of narrowed down specific items in this discussion. So, Madam Chairperson and the commissioners, really kudos to you, because once we narrow down and focus on some things collectively, there is hope.
Thank you, Dr. Khan, and appreciate the dialogue very much. All right, let's move on to public comment.
This item on the agenda offers an opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment telephonically, you may join the meeting by dialing 775-321-6111. And when prompted to provide the meeting ID, enter 981-401-478#. Please press *5 to raise your hand during the public comment periods to provide your comments. Comments will be limited to 3 minutes per person. Persons making comment will be asked to begin by stating their name for the record and spelling their last name. If you wish to provide public comment, please press *5 or raise your hand. Thank you. Ms. Schmidt.
Thank you. Good morning, Chair Sexton and Commission members. Thank you again for focusing on these important issues and for the opportunity to share comments on improving care and outcomes for Nevada's moms and babies. My name is Amy Schmidt, SCHMIDT, and I'm a Director of Health System Improvement at CoMagine Health, a national nonprofit healthcare consulting organization. In Nevada, I serve as the Principal Investigator and Project Director for the Integrated Maternal Health Services pilot program, which is currently funded by the Health Resources and Services Administration. I also serve as the Operations Director for the Southern Nevada Pathways Community Hub. We submitted public comment to the Commission on March 27th, and I'm just going to briefly summarize here based on the conversation I've heard. CoMagine Health is currently partnered with the UNLV Kerkorian School of Medicine, Department of Gynecological Surgery and Obstetrics, and the UNLV School of Public Health to launch the Integrated Maternal Health Services pilot last April. This integrated care model, which was based on 2 evidence-based models, a pregnancy health home model and the Pathways Community Hub Institute model, focuses on early entry into perinatal care and social services through OBGYN staff and community health workers partnering together to address health-related social and clinical needs to help improve morbidity and mortality for pregnant and postpartum moms and babies. We are 12 months into an 18-month pilot during which we are actively implementing our model with over 300 women seeking care at UNLV Health OBGYN clinics. And our project teams are now planning for scale and spread of this program to other OBGYN practices. But of course, we need additional funding and support. Based on past presentations, we understand that Nevada Medicaid and the conversation today intends to launch a maternity care provider pilot program to support patients and providers across the perinatal continuum. We believe the IMHS program is uniquely positioned to partner with Nevada Medicaid to build on what we've already learned over the past year. And as Director Weeks mentioned, the pregnancy health home model is a big lift for practices. IMHS can support implementation of this program for both practices as well as the community health workers. We are positioned to be piloted as a Nevada alternative payment model when an allowable Medicaid outcome-based unit rate is authorized. Therefore, CoMagin Health recommends that the PPC consider proposing legislation that would require Nevada to pursue Medicaid coverage for unallowable benefits, such as the pregnancy health home model, and CHW services rendered under the Pathways Community Hub. Funding for this pilot program and other APM pilot programs. Thank you for your consideration.
Thank you. Is anyone else wishing to make public comment at this time? Chair, I see no one else wishing to make public comment at this time.
Okay, thank you so much. Thank you again to all of our presenters today and to all the commissioners for a great and robust dialogue. I really appreciate your engagement. Looking forward to continuing the process. And again, please make sure you look out for the survey coming to you so that we can get your specific feedback and input so that we'll be prepared for our next meeting. And with that, I will adjourn this public meeting of the Nevada Patient Protection Commission. Thank you. Have a great weekend, everybody.
Thank you all.
Thank you.
Thank you.